We're now going to move on to the second panel this morning, where we just have one witness, who is Donna Ockenden, who's been conducting an independent inquiry into baby deaths at Shrewsbury and Telford Trust, which was actually something I commissioned her to do when I was Health Secretary. And that initial report was published last week, as everyone knows. Thank you very much for joining us, Donna Ockenden, and thank you for the excellent work that you've done and your team have done. And there's clearly, even though it's only an interim report, a huge amount of lessons that need to be learned. I wondered if I could just start with one in particular, which is, I think, the thing that will have shocked a lot of people when you published that report last week, which is why it took so long for these issues to come to light. I mean, they really go back decades, and knowing, as we know now, that I wouldn't have asked you to do this report in the first place if it hadn't been for the campaigning of Rhiannon Davis, Richard Stanton, Kayleigh and Colin Griffiths after their tragedies. I just wondered, what do you think was going on? Were the mistakes that led to so many deaths deliberately covered up, or was something else happening?
Good morning, Mr. Hampton, and thank you very much for asking me to join you today. I think the one issue that stands out above everything else is a failure to listen to families. As you know, the Secretary of State cohort starts in the year 2000 and our cases run up to 2019. Basically, bereaved parents pushed for the original 23 cohort to be instigated, and it was their efforts working with you that led to that. But within that cohort and earlier than that, we've come across a lot of families who tried really hard to get the system, the trust, to listen to them. And they carry on their shoulders now a huge amount of guilt because they feel that they failed to get the system to listen to them.
So I'm just trying to get a sense of scale, but you've just looked at 250 cases so far. Mm-hmm. How many preventable baby deaths do you think there were? I mean, you can't give an exact number, but what sort of scale are we talking about?
So I can only comment on the 250 cases that my independent clinical review team have looked at to date, and those findings are, very clear in our first report. We've got an awful lot more work to do, so I would have to ask you to bear with us while we complete that. But the focus, I think, is and should be on the learning that already comes out of this first report. But
of those 250 cases, what sort of scale, how many, were there 250 preventable baby deaths?
No, so the 250 cases are a selection across the cohorts, so from 2000 to 2019. So they mustn't be treated as more than an indication. And as you'll remember from the original Secretary of State cohort, there are 5 key categories. There are stillbirths, there are neonatal deaths, there are maternal deaths, there are brain damages, and then there are a category that we call severe harm to mothers or babies. So at this stage, because we know that Shropshire it's a small population and everyone knows each other, we've been very careful not to say, well, there are X baby deaths, there are X of this, there are Y of that. And I think until we publish the final report, what we should acknowledge is those 5 key categories, all of them very, very serious indeed.
Okay, I understand your reluctance when you're still in the middle of the inquiry, but I just really wanted to ask about the culture in the trust. I mean, you talked about the continual changes of leadership, I think 8 chief executives in the last 10 years. But, and you talked about not listening to mothers. But are you saying that these tragedies won't have been noticed by the trust? I mean, obviously, if they'd listened to the mothers, they would have reacted differently. But are you saying they really didn't know what was happening, or that they did know, but they chose not to take action?
So I think, and I can't stress it enough, listening or not listening to families is absolutely key. We know that many families tried over many years to get the trust structure, and that's midwifery, obstetrics, general management, and to executive level to listen. And we've seen lots of examples already in the 250 really dismissive letters, very unkind letters. And what was picked up very accurately in the media, and families themselves said it from Thursday onwards, there was also a culture of, well, this is your fault to the mother. If you hadn't done X, then your baby may have lived. So I think that's one key issue, not only not listening, but blaming mothers, which, again, mothers and fathers will tell you they've carried that guilt for years. There was also a tendency not to investigate. So there's been, I've been a head of midwifery since 1999. I clearly remember the start of an incident review process in the very early 2000s. It's when I joined Portsmouth, 2001. We were absolutely starting to investigate when things didn't go, as they should have. For a very long time, the Trust had their own mechanism. They called them HRCRs, which I've never come across anywhere else in the country, high-risk case review. So they didn't follow national guidance. And what we found, and bearing in mind my team are almost all entirely clinical, most of the week they spend out doing shifts on labour wards, antenatal clinics and whatever. What we found is that when they did investigate, if they did investigate, they often just hung their hat on the wrong hook, so to speak. They picked something that certainly wasn't the root cause. And they got diverted, so they failed to learn. And another issue that's coming up, because the Trust have now shared with us a vast amount of documentation, they've been really helpful in that, is we noticed that until a complaint came in, or until litigation was commenced, the initial Trust review simply didn't happen. So I think it's not one issue. It's not that they try to sweep things under the carpet. It's not that they just didn't listen to families. There were multifaceted things going on, and I have to say, across all professions.
Now, what was very striking, final thing from me, and then I'll bring in my colleagues, is that you made recommendations at this very early stage, not just
Yes.
for the Trust, but for the whole
Yes.
of the NHS. And I just wondered, what's your basis for thinking that this is not a one-off issue, but there are lessons here immediately that need to be learned right away for maternity services across the NHS?
So we were tasked by the Minister of State back in the summer to get out some early learning. She personally asked me, by the end of this calendar year, please, if it's available, can you get out learning for the Trust, and also please look to see if there is potential learning for the wider system. So again, as we were doing our work over the summer and into the autumn, we very clearly identified 27 local actions for learning for the Trust itself. But again, taking into account that my team is entirely clinically focused, they're there day in, day out, in their trusts, in their clinics, there started to be a realisation that although this was a review of the Shrewsbury and Telford Hospital NHS Trust, but it would make good sense for other trusts to start looking at issues to ensure that actually what was happening at Shrewsbury and Telford was not happening in their own trust. So think of it as a preventative action. Go away and look at the way you run your labour wards. Go away and look at the systems that you might have in place for risk assessment. So it was a preventative issue. Go away, please, and examine, consider what we're saying here. And I am pleased to say, you may be aware that a letter went out late last night to all Trust Chief Execs, Chairs and CCGs, telling them, reminding them about our immediate and essential actions and asking for some pretty immediate action on those immediate actions, I think by the 21st of December. So we're really pleased about that.
Thank you. Laura Trott.
Thank you, Chair, and thank you, Ms Ockenden, for this incredibly important review. One of the things we've been covering and has come up as part of this inquiry is the prevalence of ideology over views on how women should give birth and the impact that that has had on maternity safety. Now, I noted as part of your interim review findings that the caesarean section rate in the Shrewsbury and Telford Hospital NHS Trust was much lower than the rest of the country. Can you give your insights on the impact that that had overall on maternity safety and some of the drivers behind that you found from your initial findings?
Good morning, and thank you for that question. So it's very clear from our report that yes, caesarean section rates were considerably lower at the Shrewsbury and Telford Hospital when compared to trusts locally, trusts in the region and trusts across England. They're from NHS statistics, and that's really clear. Again, what I would say, this is a multi-professional issue. So we have spoken to hundreds of women who have said to us they felt pressured to have a normal birth. My clinical team have said that they've seen examples of even in situations where a normal birth in their own hospitals would be contraindicated. There were examples of women being pressured to have normal birth. But this came, and I need to be really clear here, this came from across the professions. This came from obstetricians, and this came from midwives. It wasn't solely a midwifery issue. We will be writing more about it in our next report because it's something that we need to explore. But the issues that happened at the Shrewsbury and Telford Trust were multi-professional in nature. It wasn't one profession battling against another. It was across those key professions.
You used the term there, normal birth. Is this something that you think is outdated and now needs to be changed? Because obviously normal is, the right choice for women is the safest choice. Do you think we need to look again at whether we should be using the terminology normal birth at all?
So again, I would base everything that I say and do on what families have told me. And again, I've met hundreds of families face to face in Shrewsbury, and the very clear steer from those mothers and their extended families is safe birth. They want a birth that is safe. At the end of it, they are well and in good health, and their baby is well and in good health. So for me and my team, and for the mothers and fathers who've contributed to this review today, it's about a safe birth.
Absolutely. And do you think that there is more that, and this might be something that you're covering as part of your forthcoming further review, that the NHS needs to do in terms of looking at C-section rates and how they monitor them overall, and also in terms of the information that women are given about the safety of various choices? I know this is something that you cover as part of your interim review. Are there specific recommendations that you have around that you'd like to discuss with the committee?
So I think what we've raised in our first report, in both the local actions for learning and the immediate and essential actions, is the issue of informed choice, truly informed choice, so that when women are making choices about place of birth and mode of birth, they actually make the decision based on accurate information. And that's something that we know the Trust is going to be working hard on, because they've given us a commitment that they will be actioning the 27 local actions for learning, plus now the system, as a result of the letter to chief execs and chairs last night.
Right, and do you think that that is a problem for the NHS more broadly in terms of the information that women are given about their birth choices and the various safety of the various options?
So I think what we've asked for in the immediate and essential actions is that all trusts go away and look at this. And in the letter that was sent last night, I think they cite the Chelsea and Westminster Trust as an example of good practice. So again, there are trusts, and we need to stress that there are trusts that are doing incredibly well in terms of the safety and quality of maternity services, and we mustn't lose sight of that. But the whole thrust around the immediate and essential actions was, please can all trusts look at this report and make sure that their services are as safe as they should be.
Thank you very much.
Thank you.
Thank you. Neil Hanvey.
Thank you, Chair. Good morning, Ms. Ockenden. Thank you for the report and for your input so far. I wanted to begin to explore some of the recommendations that you have put forward. But before I do, I was interested in some of the comments you just made, particularly about risk management and reporting mechanisms. And those are pretty fundamental tools to monitor and manage clinical safety in a whole range of settings. Am I correct in understanding that you found that those systems either weren't in place or just did not get used effectively?
Yeah, you're absolutely correct. In a number of the 250 cases that we've looked at so far, my doctors and midwives, who are everyday doctors and midwives in 12 trusts across England, picked up quite quickly that the root cause in a particular case simply hadn't been picked up by the local system in Shrewsbury and Telford.
Okay, and so there was no, I assume from that, if risks are not being reported, then there's no observation of patterns that begin to emerge. Was there not a concern at board level that those data, which are fundamental to any NHS organisation, were not being generated?
So again, we need to, if you remember, in chapter 3 of the report, bearing in mind this is the first report and we've still got more to do,
yeah.
Mr. Hunt says we do draw attention to the turnover, the churn at board level, at chief exec level, at non-exec director level. And that's something we do need to look at in the second report. It may well have been a factor. It may well have been a factor.
That's great, thank you. I wanted to now ask you a bit about the what you envisage the managing complex pregnancy aspect of the report in terms of how organisations are going to start to work collectively, and whether you see this as a clinical network type model, and how review, peer review and the likes will happen within those networks.
Okay, so the first thing we say is that all complex women should have a consultant lead. And in our review of the 250 cases, we found a number of cases where either women remained under midwifery care, or where they were referred on to consultant specialists, perhaps in cardiology, epilepsy, where they were then seen by junior doctors. So, a failure of consultant oversight there. And then when women should have been referred out to regional centres, they were kept in-house at the trust. So there were a number of failings that my clinical team picked up on. So what we're saying is first there needs to be local action. So trusts need to be assured that with women who are complex, they get the right oversight within a trust. So whether that's a consultant obstetrician leading on their plan of care, a consultant anaesthetist, really important member of the maternity team involved at the right time, not walking in an emergency when there's never been an anaesthetic plan for a lady. And then, and I know, for example, that London is making some really good progress on this, the ability for trust to work as part of a network of maternal medicine centres. So we know that not every, you wouldn't expect in a district general hospital, for there to be all of the specialties that women in our population might need. But, we're all talking virtually today. Ordinarily, I would have been sitting up with you in London. We've got much better, at virtual consultations. So it should be relatively easy for this kind of arrangement to be put in place. And we do think, as I said in the report, it's an urgent national priority now for all women to be able to access the help that they need from the specialists that are out there.
And the risk assessment that you envisage happening throughout pregnancy, do you see that as a vehicle to drive higher risk women into the specialist centres? Is that something that you see that being able to facilitate?
Yeah, so that could work both ways. An antenatal checkup should be a risk assessment. So at every antenatal contact, whether that's with a community midwife, a hospital midwife, an obstetrician, a GP, whoever it is in the maternity team that is seeing that woman should monitor risk. And it may well be that then what happens is the care plan stays exactly the same. The woman remains low risk, or her medical condition that she may have come into pregnancy with is well managed. And that's fine, that's a reassurance. But equally, then there needs to be a decision as to whether the woman's care needs to be escalated to a consultant obstetrician, whether she needs to see a consultant anaesthetist in her pregnancy, or indeed whether the skills are not present within that hospital and specialist help needs to be sought from within the region.
Okay. Can I ask one final question, Chair? What barriers do you envisage to making your recommendations a reality? And if you were to ask for a wish list of 2 or 3 particular aspects of support, what would they be?
So I'm really pleased. I was up very late last night. I'm really so delighted that the national system, has now written out to all chief executives and chairs and CCGs, highlighting the key issues. So there are the 7 immediate and essential actions, and what has been highlighted from within them, because there are subsections, are the key issues that could be acted upon now. And risk assessment is one of them. Listening to women's voices is another one of them. So I do feel confident that, it's only Tuesday today, and I'm speaking, to this committee, giving evidence to this committee. A letter's already gone out, across the system. I do feel confident at this stage that everyone has understood the seriousness of the issues both raised in Shrewsbury and Telford, and the absolute need for the wider system to look at everything that we are saying.
Fantastic. Thank you ever so much for all the fantastic work you're doing. Well done.
Thank you. Thank you.
Rosie Cooper.
Thank you, Chair. I'd like to thank you for all the valuable work that you're doing. And just to go on the point you just made about confidence that the system is listening, I suppose I want to say that Robert Francis and the eons of people who've made recommendations following inquiries have always hoped that things would improve. And we haven't really seen that almost generation of improvement that we needed. In this, your 7 immediate actions and key recommendations, they're really common sense, they're not earth-shattering, they should have been happening anyway. Here you indicated that the board oversight wasn't good, the board and management were not listening to patients. So my question relates to the higher deafness, the deafness of regulators who I would say are missing in action in most of these inquiries. The CQC, the Department of Health itself, NHSEI as it is now, or the TDA as it was. And then what is the point of staff and patient surveys? We've invested a lot of time and money in getting these things on the table from previous inquiries, and yet they've all failed here again as well. So how can you feel more confident that we can wake up the regulators? They cost us a lot of money, and make this work for patients.
So that's a really good question. Essentially, this first report is about immediate actions for learning, and you can see that in chapter 3 of the report there is a brief outline. It's only a few pages of the things that we will be considering in more detail. We talk about the role of the CCGs, the board, the CQC, statutory supervision of midwifery that was around until 2017. So please be assured that we will leave no stone unturned in assessing the role of all of these systems. But what we felt in terms of getting real clinical actions out onto the ground before Christmas, that's been our main focus in this first report. But please be assured that all of this is underway, and you know, we won't shirk from our responsibilities in calling this out if needed.
That is really good news. So Bill Kirkup's doing another inquiry. So between you, I only hope and pray that we have a major influence on the system. Can I just ask you one further question? A clinical question. We hear a lot about a team of midwives. The team of right midwives will make a huge difference to the care of mothers. And it is very appealing, but I was chair of a Liverpool Women's Hospital in the late 90s, and I didn't manage to get in to ask Professor Knight whether the model had been costed, both in terms of, it's not a new idea because Baroness Cumberledge actually promoted this in the 90s. And my belief is that due to huge extra costs, and I don't mean a few thousand, a few 100,000, we're talking millions, and the lack of staffing, this never got off the ground. Do you think that the model's been costed and it could work today? Do we have the money and do we have the staffing to do it?
So that's not something that we've focused on in this report so far. Obviously, we've looked at the 250 cases, and this issue of continuity of carer, I think you're describing, we used to call it team midwifery, as you say, in former times, didn't come up as an issue that would have influenced the women's care. So it didn't come up as, if only we'd had that, it would have made a difference. Now, I was a head of midwifery from 99 until 2014, so a long time, and I do recognise, you know, the workforce constraints and difficulties. And so I think if I was to ask for one thing, it would be multi-professional working, and actually two things, and the continual risk assessment of women throughout pregnancy, rather than hang my hat on one particular model.
Thank you very much.
Thank you.
Thank you. And finally, Sarah Owen.
Thank you, Chair, and thank you, Ms Ockenden. You've talked a lot about enabling women to make informed choices, and women need to be informed free from ideological bias. So when discussing my mode of birth earlier this year, I was given a list of risks when it came to a C-section, but I really had to push and question what the risks were for a vaginal birth. Why do you think there is an ideological preference for non-assisted vaginal births from some maternity teams, and how ingrained do you think that ideology is?
So we saw, and it's very clear in our report, this very big difference in the C-section rate between the Shrewsbury and Telford Trust, at other local and regional trusts and across England. We need to look at this in more detail in our second report, but what was very clear was this was a multi-professional effort. So, you know, we know that the obstetricians were very much leading the way in Shrewsbury and Telford in terms of the push for normal birth. A number of my obstetricians have commented that, you know, in some of the scenarios where normal birth, if you can call it that, was achieved, they are very, you know, I've got very, very experienced obstetricians on my team, and they'd have said, absolutely not. This, you know, under my watch, on my shift, on my labour ward, this would not have happened. So I think it's really important to say that at this trust, it was a multi-professional, not just midwifery-led focus on normal birth at pretty much any cost. And, you know, it is also very clear, I think, in our report that there were times, there were occasions, there were cases when, had a baby been delivered by a caesarean section, the outcome may well have been better and almost certainly would have been safer.
Thank you. I just wanted to dig a little deeper, because that doesn't just come about organically. Why is it, do you think, that ideological bias towards vaginal birth was so embedded and so widespread?
So we've still got an awful lot of evidence to review, which will be part of the second report. What we've managed to say to date in this first report is that there were a number of cases where caesarean section should have been used earlier, and had it been used earlier, the outcome for mothers and babies would have been better, would have been safer. So the Trust have worked really hard to amass a vast amount of documentation that we've received in early November, and we'll be making our way through that. And what we can promise you is that we will be looking at this in much greater depth in the second report later in 2021.
Thank you.
Thank you.
Thank you. Barbara Keeley.
Thank you, Chair. It's just a follow-on from what Sarah has just been asking. I just wonder if you believe it is possible to change that deeply ingrained culture across professions, as you said, where the view is that they know more than the woman giving birth, how she should give birth, as indicated by the use of that term that we've been discussing, normal birth. Clearly, you can point to trusts where it is being done well, but how possible do you think it is to change that? Because we've heard earlier when we were looking at the example of black mothers where maternal mortality and baby deaths were much higher, that a mother felt she had let the midwife down. I mean, where are we with care when somebody feels they let the midwife down from having a C-section rather than a vaginal delivery?
So I did just catch the tail end of that conversation, and it's, having been in and around maternity services and women and children's divisions now for over 30 years, that is such a sad story to hear. To my mind, it has to be about women being equal partners in their care. And I know that there are a lot of trusts, doing that very, very well. And I think we need to call it out for what it is, which is unacceptable if women and their families, because I've met countless husbands and partners in tears because, they felt they let the system down, as well, for not playing a strong enough role. I think we need to call it out for what it is, that childbirth and the arrival of a new baby should be the most joyous event in a family's life, and it's simply unacceptable if what we leave along the way are instead broken families and women who carry guilt on their shoulders for many, many years. And I will be the strongest advocate for women that I can be, that I hope I've been throughout my career, but I'll continue to speak out on this for as long as is necessary.
Okay, thank you.
Thank you.
Thank you. Just a final question from me. How much would it have helped the families you've spoken to if their child's death had been investigated independently right from the outset?
So I think what I would say to that is, again, I've referred to the fact that I've been in and around maternity services, for about 30 odd years. And I've got very clear memories of very effective investigations done locally with external expertise called in as required. Certainly, in my days in Portsmouth, we were doing that from the early 2000s onwards. I think, Mr. Hunt, this is about leadership. I absolutely treasured my role as head of midwifery and divisional director, and I took huge personal responsibility in ensuring that if things went wrong, and they can go wrong sometimes in the very best of services, that families felt satisfied that any review or investigation that was done was of the highest standard. So I think this all goes back to leadership locally within the trust, the ability of the head of service, so the head of midwifery, to talk to and interact with the board on an as required basis. And I never came across any barriers to talking to my boards and getting them to listen. And then the families, I think what is really important is that if something goes wrong, what we want is for families then to have confidence to be able to go back to their local services to continue to receive healthcare. So I think there's got to be something about skilling up local and regional services to make sure that they do investigate appropriately and they do then build those relationships with families.
Thank you very much. Well, that concludes this panel. And Donna Ockenden, thank you very much for joining us, and thank you again for the hard work that you've done and that your team have done to get to this very important interim report that you published last week. And as you say, it's very encouraging that the message has now gone out to the whole NHS about lessons that need to be learnt immediately. So thank you very much indeed for joining us, enormously appreciated.